Hi, everyone. Welcome to Podcasts for Patients. My name is Lee Clark, Director of Patient Services, and I'll be moderating the podcast today. Before we get started, I'd like to thank our Diamond Level sponsors, Alexion and Novartis, and of course, our patients and families and caregivers who support our educational programs. Today, I have the pleasure of speaking with Rory Shallis, who is a physician at Yale Cancer in New Haven, Connecticut. Thank you so much, Dr. Shallis, for joining us today.
It's a pleasure. Thanks for the invitation.
Imetelstat was recently approved for treating MDS. And can you tell us a little bit about what is the new therapy?
Sure, it's an important question. Imetelstat uses what we call a novel mechanism where it works in a new way. It's a first-in-class competitive inhibitor of telomerase, which is an enzyme that works to, has a couple of functions. It works to protect and even make more telomeres, or the caps, if you will, on the end of chromosomes, which is kind of like these large structures of genetic material that all of our cells have. And it protects them from a sort of cellular retirement and from damage for those that have not yet retired, if that's the way you can think about it. Malignant cells, like those found in MDS, appear to rely upon this enzyme to protect them. So it not only made sense to try to target this aspect of the malignant cellular machinery in these cells, it just took time to develop and study a drug that did just that. Imetelstat was shown in early experiments to inhibit telomerase activity and the proliferation or growth of these cells in various cancers, including MDS. Imetelstat showed promising results in an initial phase 2 trial that were, as you might be aware, confirmed in a randomized phase 3 trial that eventually led to its approval on June 6th of this year.
What patients would most benefit from the treatment?
Sure, this is a good question. I think it's still being debated as to whom it might exactly apply. I can tell you the randomized trial studied imetelstat in patients with lower risk MDS that had already been failed by what we call an erythropoiesis stimulating agent, or ESA. So at a minimum, these patients for whom the treatment would be reasonable and for whom the drug was approved. Particular subgroups may be more attractive for this treatment, but this requires a bit more research, and we wait to see, in all honesty, how the NCCN guidelines may respond to this as well.
How is the treatment given and what are the known side effects?
Of course. Imetelstat, it's administered as a 2-hour-ish infusion intravenously or IV through the veins. It's given every 4 weeks. The side effect profile is largely navigable, I'd say. It does require some vigilance on the part of providers and patients. The key side effect that did get some press is a lowering of blood counts, including low white blood cell count, low platelet count in the majority of patients, where at least weekly monitoring, in some cases more often, is recommended, with consideration perhaps for growth factors, mind you, myeloid growth factors, some maybe prophylactic antibiotics, and uncommonly a platelet transfusion or two. However, the vast majority of patients had this as a short-lived side effect in the order of maybe 4 weeks or so, and limited episodes of recurrence beyond the first cycle or so. Other side effects include liver irritation, headache, fatigue, muscle aches, but these are, I would argue, likewise, fairly manageable and acceptable given the benefits that have been thus demonstrated.
Can you tell us a little more about the clinical trial that led to the approval?
Of course, this is the iMerge trial, which was a phase 3 randomized, double-blind, placebo-controlled trial of this drug, imetelstat, or placebo. Kind of like the gold standard of trials to really demonstrate whether a drug is truly working. And this was amongst patients with lower risk MDS. Just under 200 patients were on the trial. Treatment arms were, by design, balanced for patients who had certain degrees of red blood cell transfusion burden and a certain measure of MDS disease risk. So it was a cleanest kind of appraisal of how this drug is really doing compared to placebo. The specific target for how well this drug worked was an 8-week period, a protected 8-week period of not needing a red blood cell transfusion. 40% of patients receiving imetelstat hit this target, compared to 15% of patients receiving placebo. So clearly indicating effect of the drug.
What is the difference between luspatercept and imetelstat?
A lot. Luspatercept is what we know now as an erythroid maturation agent, or we still, or can call it a TGF beta ligand trap, fancy terminology for a drug that works in somewhat of a new way or new ways. It's a subcutaneous or under the skin injection every 3 weeks, and appears to have a much better effect for patients whose disease harbors what we call ring sideroblasts. We've been using this drug for a few years now and tend to recommend it for patients with this exact situation. So MDS with ring sideroblasts, different ways of defining it. Although it does have some effect in patients with disease outside of this particular subset. There's likely to be some overlap in the particular patients that may have a path to being recommended for a particular treatment like luspatercept and or imetelstat. And it may take some time, in all honesty, to really sort out which one is more attractive for particular patients, because we, as of yet, do not have a comparative study. There's no randomized phase 3 trial comparing luspatercept to imetelstat. But we certainly, for the time being, welcome new additions to our toolkit to help patients with this disease, which, is in need of newer therapies for sure.
What else is important for patients to know about imetelstat?
This regimen can be navigated safely. You get through the side effects. There are other options that can be considered for the patient being considered for imetelstat, including lenalidomide, luspatercept, as we've talked about, or in some cases, a hypomethylating agent. But these options should be weighed against each other and against imetelstat, hopefully with the assistance of an MDS specialist. So I would probably just counsel patients to ask your provider for a second, if not third opinion, if you're not already seeing one.
Well, thank you very much, Dr. Shallis, for sharing your time and your expertise with us today. And if you'd like more information about MDS and other treatments, please feel free to visit our website at aamds.org or give us a call at 800-747-2820. And if you're looking to find an MDS specialist, please feel free to let us know and we can help you with that as well. Thank you so much, Dr. Shallis, for sharing your time today. Have a great day.
Thank you so much. You as well. Take care.